So background, as we know that compared to primary PCI, pharmacoinvasive strategy has an equivalent clinical outcome as shown in STREAM trial and in India in STEP AMI trial by Victor et al. Switch over from clopidogrel to higher potent P2Y2 inhibitor is preferable during pharmacoinvasive PCIs as shown in STAMPA trial. And after fibrin-specific thrombolytic therapies, this switchover should be safe after 24 hours as per the international expert consensus document. Pharmacoinvasive strategy beyond 24 hours is also beneficial as per the CAMIR registry, and problems of PCI in pharmacoinvasive and primary PCI are same such as no flow and reflow. So both Ticagrelor and Prasugrel are class 1 recommendation for treatment of STEMI undergoing PCI. However, clinical efficacy in various trials has been conflicting due to differential effect on microcirculation as we proposed. Theoretically, Ticagrelor is superior to Prasugrel as it inhibits the adenosine uptake by decreasing reperfusion injury, by increasing coronary blood flow and decreasing infiltration by neutrophils. In IRSA 5, it has been shown that Prasugrel is superior to Ticagrelor in terms of MACE and also reported less bleeding complication in ACS patients. However, there are only 40% of STEMI patients and no effect on microcirculation reported. In the period of COVID-19 pandemic, pharmacoinvasive PCI was a strategy in our center based on the protocol as per the CSI document on acute AMI during COVID-19. No study till date has compared the effect of Prasugrel or Ticagrelor on coronary microcirculation in patients undergoing pharmacoinvasive PCI. So we aim to perform this study with a primary aim to compare the effect of Prasugrel and Ticagrelor on coronary microcirculation in patients undergoing pharmacoinvasive PCI as assessed by myocardial blush grade. The secondary aims are to compare the effect on coronary microcirculation in patients of STEMI as assessed by corrected TIMI frame count, to compare the change in ejection fraction between the two groups, and to compare MACE and bleeding events in hospital and at 6-month follow-up. So this is an open label randomized controlled study done from March 2020 to February 2022. This is how I calculated the sample size based on the study by Philho et al. Where Prasugrel achieved approximately 85% of myocardial burst grade 3 and Ticagrelor achieved 67%. So accordingly, 226 patients would be sufficient to achieve 90% of power with two-sided alpha level of 0.05 with equal recruitment in both the groups. Hence, a total of 240 patients were planned to enroll with 5% attrition rate. So this is my inclusion criteria. I included all patients of STEMI more than 18 years of age who underwent successful thrombolysis defined by relief of chest pain and ST resolution more than 50%. And these are my exclusion criteria, namely contraindication to use of either drug and 100% occluded vessel in a coronary angiogram. So STEMI patient after successful thrombolysis, after 24 hours we evaluated for the enrollment, and 1:1 randomization was done, and those who are amenable to PCI, 120 patients in each group were taken, and as myocardial blush grade and corrected TIMI frame count was assessed by the two blinded observers blinded to the treatment, and then follow-up was done at 1 and 6 months. Statistical analysis was done using the SPSS 25 software, and standard method of statistical analysis was done. P-value less than 0.05 was considered significant. So this is my results. Mean age of the population was 50 in both the groups, with majority of the population are male. Symptom to lysis time is 5 hours in both the group approximate, and lysis to balloon time is 40 hours in both the groups. Drug to balloon time is 2.5 hours. Majority of the patient in our study are anterior wall MI, approximately 55%, and the biochemical parameters are similar between both the groups. So these are my baseline angiographic parameters. As we can see that the majority of the population in our study belongs to had a pre-procedural TIMI flow of 2 and 3, approximately 70 to 80%, and the thrombus grade of 2 to 3 in approximately 80% of the population. So this is the main slide. Effect on coronary microcirculation. Here we can see that post-procedural TIMI flow and myocardial blush grade is more with group on patient of group B, that is on Prasugrel, as compared to those on group A who are on Ticagrelor, which are statistically significant, and thus resulting in a lower TIMI flow corrected TIMI frame count in patient on Prasugrel as compared to those on Ticagrelor. The bar diagram on the right is shown that the myocardial blush grade is more with patients on Prasugrel as compared to those on Ticagrelor, which is statistical significant myocardial blush grade 3. So the comparison of ejection fraction between the two groups, as we can see that both ejection fraction is shown, both drugs showed improvement in ejection fraction. However, this improvement is more with group on Prasugrel. So in a hospital, MACE event was similar in both the group, and at 6 months it is more with Ticagrelor, attributed to high reinfarction rate. This is the first adequately powered study to compare the effect of P2YT inhibitors on coronary microcirculation. Prasugrel is shown to be superior to Ticagrelor to improving coronary microcirculation by Philo et al. In this study, we report that Prasugrel was superior with respect to primary outcome as assessed by myocardial blood gauge and corrected TIMI frame count. Change in ejection fraction is comparable to baseline and was significantly higher in patients on Prasugrel compared to Ticagrelor. There is no significant in major and minor bleeding. This is the parameters: stronger platelet inhibition, reduction in pro-inflammatory cytokines, and less damage to microcirculation may be the cause why Prasugrel is beneficial. So limitation: it is an open label study, short duration of follow-up, more objective methods such as microcirculation obstruction and IMA was done, and ejection fraction was not success. This is my final slide. Conclusion: Prasugrel produces greater improvement in coronary microcirculation than Ticagrelor, resulting in improved myocardial salvage in patients of STEMI undergoing pharmacoinvasive PCI. Thank you.